I am Dr. Saifur Rahman, now presenting a comprehensive review on LTRA as add-on therapy option in bronchial asthma, particularly poorly controlled by inhaled corticosteroids. We know inhaled corticosteroids are mainstay of current asthma management and should be used in all patients with persistent asthma. Many patients with persistent asthma can be controlled with regular inhaled corticosteroids. However, a considerable proportion of patients treated with ICS remain symptomatic. To deal the problem, several options have been separately assessed in several reviews, systemic reviews and meta-analysis. The aim of our article is to review the evidence that supports the use of LTRA as add-on therapy option to demonstrate whether more benefit can be obtained by adding LTRA to the treatment than by increasing the dose of inhaled corticosteroids. The paper reviews studies where participants were adults or adolescents with clinical evidence of asthma not adequately controlled with ICS. The general inclusion criteria in these reviews were randomized, blinded and controlled trials with either parallel group or crossover design published as a full-length paper. We know cysteine-nicotine receptor antagonists such as montelukast blunt the obstructive response of bronchial asthma and have weak anti-inflammatory activity. In some studies, corticosteroids are not very effective inhibitors of cysteine-nicotine pathways. In one study with patients, number 642, with symptomatic persistent asthma, despite the treatment of beclomethasone 400 microgram per day, addition of montelukast 10 milligram per day improved morning FEV1 and peak expiratory flow rate, asthma symptom score and the percentage of asthma exacerbation free days better than placebo during 16-week period. The increase in morning FEV1 was approximately 140 ml and peak expected flow 10 liter per minute. There was a tendency towards reduced rescue medication use with the combination therapy. Addition of montelukast to inhaled corticosteroids seemed to prevent the increase in the number of peripheral blood eosinophils seen in other treatment groups. This is showing the changes in peak expected flow rate in different groups. The additional anti-inflammatory activity obtained by adding montelukast to the treatment regime has been assessed in 3 randomized double-blind crossover studies lasting for 8 weeks. In one study, addition of montelukast to salmeterol and fluticasone combination was compared with placebo in patients with mild to moderate asthma. Compared with salmeterol fluticasone running period, adding montelukast was better than placebo for inflammatory markers and blood eosinophils. According to a recent meta-analysis, leukotriene antagonist combined with inhaled corticosteroids 300 to 2000 microgram per day reduce the number of patients with exacerbation that require systemic corticosteroids compared to inhaled corticosteroids alone. There was no difference in side effects. Addition of salmeterol seems to produce better improvement of asthma control when lung function is assessed than addition of montelukast in patients with asthma suboptimally controlled by small to moderate dose of inhaled corticosteroids. However, in one long-term study, addition of montelukast to fluticasone was shown to be not inferior to addition of salmeterol when the percentage of patients with at least one asthma exacerbation was used as the primary endpoint. Whereas addition of salmeterol may produce a better improvement in lung function, addition of montelukast may provide additional anti-inflammatory efficacy to inhaled corticosteroids that is reflected in a long-term efficacy on asthma exacerbation. In addition to the normal clinical endpoint, the effects of addition of salmeterol or montelukast to the treatment regime were analyzed on AMP bronchial challenge, blood eosinophil counts, and exhaled nitrous oxide in a placebo-controlled double-dummy crossover study in patients with persistent asthma not controlled with ICS. For the provocative concentration of AMP causing a 20% fall in FEV1 compared to placebo. There was significant difference in the first last dose of montelukast as well as the first and not the last dose of salmeterol. So there is some tolerance to salmeterol. This is dose-response relationship curve for ICS. So there is significant improvement with the first dose of salmeterol for all parameters of lung function. After 2 weeks of treatment, there are significant improvements with both drugs on rescue bronchodilator requirement and morning peak expected flow. There are no significant difference between the drugs for any endpoint except blood eosinophils. Thus, the results suggest some anti-inflammatory activity for montelukast when used as an add-on therapy. Addition of the montelukast improved asthma control in patients remaining symptomatic with inhaled corticosteroids, and addition of montelukast may be equal to double dose of inhaled corticosteroids. The long-term efficacy of montelukast on asthma exacerbation may be equal to salmeterol. Thank you for patient care.
Thank you, Dr. Saiful, for your well-known presentation. Our